Next, well, first I just want to preface a couple of the talks at the end of the day today. A few of our parent ambassadors have been so kind to come up ahead of the talk and share a little bit about their lived experience on the subject. And so the next talk is going to be presented by Dr. Priscilla Duong from Lurie Children's Hospital on neuropsychiatric care in Dravet syndrome. But we're first going to have caregiver Brian Wilson come up and give a little bit of his lived experience with behavior and neuropsych issues.
Fortunately for everybody, I don't have any slides. But I do want to thank all the doctors and scientists presenting. I think this is always my favorite day of Dravet because it's the kind of stuff I could never wrap my head around, but I get a chance to do so. So thanks to everybody who comes to present and does all the research. So I was asked to talk about some of the behavioral issues that we see with our Dravet kids. You know, in the beginning of Dravet syndrome, it's the whole life or death situation of seizures. Living in the hospital, wondering if your kid's going to survive. But then as Dravet goes through its natural course and through combinations of medication and the morphing nature of Dravet syndrome, suddenly those seizures start to normalize, and your child who is usually out cold or very lethargic because of all the activity suddenly becomes awake. And with that comes behaviors, and it becomes a whole new battle that we undertake. I'm sure any of the parents here have plenty of stories that we could tell. I'll try to limit it to just three here. You know, Vivian, my daughter, she's 13 now. She loves chaos and messes. If she walks into the kitchen and the towels are hanging on like the dishwasher, she immediately yanks them down. She loves ripping up and destroying stuff, so she's our personal shredder. We call her a bespoke shredder, and we always think we can take her over to Brooklyn and sell her services for like bespoke paper shredding. But it gets to the point where it becomes very, very interruptive. She'll rip up junk mail, cardboard. She once ripped up some money we left out before we understood this. But she will not eat dinner. If she gets hold of some of the junk mail or a large piece of cardboard, she will not eat dinner until she finishes that. We call her the most dedicated worker because she's working overtime to get this done, and we're trying to tell her, take your break and eat. But it's getting close to bedtime, and she is so persistent in it that if you try to take it away to get her to eat, she will not stop. And there's not much we can do except for like get stressed out because we need to get bedtime going, we need to get meds going, but she will not stop until she gets that done. So there's a strong persistence or perseverance to complete these activities. Another danger we run into with her behaviors is simply she will not wear snow gloves, she will not wear a hat, and she wants to go outside all the time. And again, these behaviors, you see your kids are very, very persistent on doing it. Outside, 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 starting to hit herself if we say no, but yet it's snowing and there's a foot of snow or 6 inches, whatever, on the ground. She won't wear the gloves. And she'll go out, and then her hands will start turning red, and she doesn't get it, right? And then we try to bring her inside, or it could be raining out, right? If it's raining, again, outside, 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 hitting herself if she won't do it, and every once in a while, I'll let her go outside. And she starts walking into the rain. She gets really upset that it's raining, but there's this disconnect between understand, I don't like being in the rain, this is uncomfortable, but I want to be outside. And she'll stay outside until I forcibly bring her back in because she wants to be outside, but she doesn't connect the negative of being there with the positive. So a lot of these behaviors become really, really challenging. The last one we have is just we have to lock everything down. Every time we have guests over, we have to explain to them, no, we're not like the comic strip Kathy where we have the refrigerator locked up because we're on a constant diet. If we don't have the refrigerator locked out, Vivi will empty it every day. If we don't have every single door in the house closed, if we don't have every drawer and cabinet locked and latched down, she'll get into it and empty them. So there is a big shift in life or death with seizures in the beginning to constant, smaller, but never-ending annoyances of behavior. And I think that's one of the challenges that we as parents have to face and get through. So I'll leave it at that. Thank you, everybody.
Thank you so much, Brian. I just feel like that provides so much insight into the reality of Dravet syndrome before we go into a more clinical talk. So thank you. And I will hand it over to Priscilla now to go through her talk on neuropsychiatric care. Thank you.
All right, so I'm going to talk about neuropsychiatric care in Dravet syndrome, and as mentioned, I'm Dr. Priscilla Duong. I'm a pediatric neuropsychologist at Lurie Children's Hospital. So I'm going to start by talking about common neuropsychiatric comorbidities, talk about the assessment of those comorbidities, and then I'm going to go into therapies and interventions, academic supports, and I'll touch on transition planning as it pertains to school and decision making. So as you all know, Dravet is an epileptic encephalopathy that carries many neuropsychiatric risks that impacts an individual's daily functioning. So the information on these comorbidities that I'll be presenting on today represents the last decade or so of research, but with disease-modifying therapies, we're also hopefully starting to see a change in this clinical picture. So as you know, development may appear normal in the first year of life, but neurodevelopmental impairment is often observed by 2 to 3 years old. And so a study looking at 355 children with Dravet, we see that in that first year of life, development typically looks normal, so represented by the orange, but by 2 to 3 years old, we see more noticeable impairment. And rather than a decline, there's usually a developmental stagnation, meaning that children are slow to make progress, so they're not meeting their milestones, or they're not making as much progress as expected for their developmental age. Although regression is also seen, it's more rare, and usually in the context of a prolonged seizure. So some predictors of negative developmental outcomes include the presence of a motor disorder, abnormal EEG in the first year of life, status epilepticus, and early focal seizures with impairment of awareness before 2 years old, young age of onset of myoclonic seizures, and having earlier developmental delays. So many times these developmental delays progress and become an intellectual disability. So what is that? There are deficits in reasoning, problem solving, and planning that impacts an individual's daily living skills, so including communications, social participation, and independent living. And this is often solidified by 5 to 6 years old. And this is common in intellectual disability, given that there's a lot of variability within that first few years of life in terms of development. And some children with delays may catch up, for example, but by 5 to 6 years old, we see that there's if there are still extensive delays, it's hard for children to catch up, which really also makes it important for us to think about early identification and early intervention that may help close these gaps as much as possible. And in terms of the severity, so most individuals with Dravet syndrome meet criteria for severe to profound intellectual disability, so 38%. And what that means is that broadly speaking, they may be functioning more at an infant to toddler level, developmental level. But of course, within all of these severity levels, there's quite a bit of variability. So it's not fair to say that in all skills they may be presenting at this level, but broadly speaking, this gives us a scope of how to best treat and different interventions that may be helpful based on where they're developmentally at. So 26% present with moderate intellectual disability, so there's quite a bit of range in terms of functioning more at a preschool to early first grade level, and then 22% with mild intellectual disability, so thinking all the way from first grade to up to sixth grade level, and then 14% with borderline to normal intellectual functioning. So some studies have attempted to better characterize the neuropsychological profile of Dravet syndrome, and they have found that verbal language skills typically seem more preserved or more commensurate with overall intellectual functioning, whereas there may be more significant deficits in attention and executive functioning, visual motor integration, and visual perceptual skills. And while speech or language skills tend to be more preserved, they may be characterized by more imprecise articulation and abnormal tone and prosody. And so this study from Battaglia and colleagues looks at developmental quotient. So what that is developmental age divided by chronological age times 100 to better characterize the percent of their developmental level. And so from 85 to above would be normal development. From 70 to 85% would indicate a mild to moderate delay, and 70% and below would indicate a more severe delay. And so what they found is in their sample of 34 children in the first 6 years of life, they saw, consistent with the other literature, that individuals typically have more typical delay in that first year. And then they found 3 different subtypes. So 2 of their patients had normal development throughout the 6 years. There was also a subset that had earlier global delays from an earlier age, so within that first 2 years. And then there was also the most common type, or the most common profile, was individuals who had earlier visual motor impairment between the ages 2 to 3 years old, and later on developed or had more significant delays globally. So visual motor impairment may be an earlier indicator that there may be slowing of development compared with verbal language skills. So another comorbidity is autism spectrum disorder. So to meet DSM-5 criteria for autism, there needs to be 2 main criterion met. So criterion A is deficits in social communication across multiple contexts. And so that means that there are deficits in social emotional reciprocity, nonverbal communication, and developing and maintaining and understanding relationships. And to meet this criterion, you can have these symptoms presently or also historically. For criterion B, there needs to be a pattern of restricted or repetitive behaviors, interests, and activities. And only 2 of the following need to be met either presently or historically. And this includes stereotyped or repetitive behaviors, so that can be repetitive body movements or speech patterns, insistence on sameness or inflexible adherence to routines, restricted and fixated interests, and hyper or hyporeactivity to sensory input. So autistic features are observed in from 60 to 97% of individuals with Dravet syndrome. And the higher percentage may represent if you also include speech delay. But many individuals might not meet criteria because they may have more preserved social skills or even hypersociability, which comes with its own concerns if individuals have differentiating whether someone is a stranger or someone that may harm them. 20 to 40% of those of individuals with Dravet syndrome do meet full criteria. And in a sample that Lee and colleagues followed, they saw that all of the individuals in their sample, so they saw 24% in their sample had a diagnosis of autism. Of those, all of them had speech delay, narrow interest, and limited and atypical emotional reciprocity. There was also a high co-occurrence of adherence to routines and a short temper. And then 44% of those had a language regression. And this differs from the individuals that didn't have diagnosis of autism who still had speech language delay, but none of those individuals in this specific sample had a language regression. So risks for autism include higher or earlier age of seizure onset, so before 1 year old, and greater cognitive impairment. So there's over 90% of those with Dravet syndrome with autism also have a comorbid intellectual disability, and they tend to be more severely impacted, so typically in the severe to profound intellectual disability range. And then 67% also have co-occurring ADHD symptoms. Interestingly, in adulthood, there's actually a decrease in use of pharmacologic interventions and less hyperactive behaviors. So some of those externalizing behaviors actually decrease, which we'll talk about in the context of Dravet syndrome more broadly as well. So another comorbidity is ADHD. So ADHD, or attention deficit hyperactivity disorder, is an umbrella term that describes 3 different subtypes. So the first one indicating that an individual presents with more inattentive symptoms, one of them being more hyperactive or impulsive symptoms, and then one being more of a combined presentation, so meaning that they meet criteria for both the inattentive and the hyperactive impulsive type. Individuals with Dravet typically present with more of the inattentive symptoms. So the prevalence of ADHD and Dravet syndrome is somewhat more elusive compared to intellectual disability and ADHD, given limited studies that use standardized assessments. And this is further complicated by, in the context of intellectual disability. So many of the measures that are that specifically look at attention deficit are not normed on individuals with intellectual disability. And it is estimated that 20 to 60% of individuals with Dravet syndrome have ADHD. And there's, in general, an overshadowing effect that may happen in Dravet syndrome, in that people or clinicians may be more likely to attribute their presentation to the medical disorder and dismiss some of the neuropsychiatric presentation. But conversely, as I mentioned, sometimes there's also the problem of clinicians having difficulty differentiating whether or not these symptoms are beyond what we'd expect for the child's developmental level. So if they're broadly functioning at a 2-year-old level, are their attention skills commensurate with that, or is it beyond what we'd expect even for that developmental level? So risks for ADHD are those who meet criteria, those who met criteria for ADHD tended to be younger and have more autistic features. So again, we see a pattern of some of these externalizing behaviors not being as noticeable later in life. And then also those who had trialed contraindicated anti-seizure medication, so sodium channel blockers, were actually 11.6 times more likely to meet criteria for ADHD. So broadly speaking, individuals with Dravet syndrome are more likely to have emotional and behavioral challenges. This study I really liked. It's a qualitative study that came out last year that looks at what parents experience on a daily basis, because as presented on Vivian, I think it's really important to capture that experience that can't be captured fully through a questionnaire. Is there aggression, yes or no? And so some quotes that I thought were, that relate to the experience, I'm gonna read a couple. So I can't go to the supermarket with her because she fills the shopping cart and doesn't take no for an answer. We've tried and for another parent, we've tried 100,000 times to teach her how to look before crossing the road. But if she sees something she likes across the road, she crosses without looking. Quotes about internalizing behavior. So he constantly seeks reassurance. He asks a lot of questions. All the questions irritate those around him, and the need for constant reassurance irritates people too. And he's aware of this irritation. The rigidity has become prominent in the last 5 years or so. His compulsive behavior combined with the rigidity makes it very difficult. He is like, can I ask for something? Can I ask something? It's not a discussion, and this is a repetitive behavior that takes hours. So in the earlier years, so from 3 to 13 years old, we see more of these externalizing behaviors, so aggression, and there's more impulsivity and hyperactive behaviors and some self-harming behaviors. Then from 14 to 22 years old, we actually see a shift where there's actually more of internalizing behaviors, so more of the compulsive behaviors or ritualized behaviors, and more anxiety. I'm also going to touch on sleep, and I know there's another presentation on this, but This is important because poor sleep can impact seizure control, but also has downstream effects on daily functioning. So 75% of individuals with Dravet syndrome in this Lycheni study was found to have sleep disturbance. And this can be reflective of impact to neurological sleep networks compounded by nocturnal seizures, side effects from anti-seizure medications, and there's also comorbidities with other neurodevelopmental disorders that are known to have higher prevalence of sleep disorders such as ADHD and autism. And what we see from this study is that there is some differences across age in terms of the type of sleep problems that are reported. Most commonly, we see disorders of initiating and maintaining sleep, sleep breathing disorders, and sleep-wake transition disorders. So how about the impact on quality of life? So looking at the relationship and how these things are all impacting each other, we see that seizure severity doesn't actually have a direct impact on quality of life. And certainly it can, but based on this research, we actually see that it's the direct cognitive impact of the seizures, and the cognition actually has a direct impact on quality of life. And we see that problematic behaviors also feeds into quality of life. So now I'm going to go into assessment and treatment. So I'm going to caveat this section of the talk with what I'm talking about are based on what is evidence-based for comorbidities or my own clinical practice and discussions with colleagues on what is recommended. But there are no clear practice guidelines on timing of evaluations. So how frequently, how soon this should be happening. And there are also no clear evidence-based treatments that are specifically for Dravet syndrome. So this is an area of research that needs to be done. So at the time of diagnosis, children with Dravet should be referred for developmental assessments. So this can include neuropsychological or developmental or psychological assessment, including diagnostic evaluation for autism, which can occur as early as 1.5 years old. Speech language, occupational, and physical therapy evaluations are also recommended. And if a child is from 0 to 3, they qualify for state-funded early intervention programs that will do that assessment, and that allows them to receive interventions through early intervention. Of course, this can also be pursued through private therapies as well. So ongoing neuropsychological developmental monitoring is recommended. Again, the frequency is, there's not a clear practice guidelines, and it may be dependent on the stability of the condition. So it can be up to yearly, but there may be longer durations based on stability. So knowing that for an individual who has a stable cognitive profile, that usually individuals tend to stay on that profile or along that trajectory when it is stable. So annual would be probably too often, but certainly around transitional times are important to best update what treatment or therapies are needed and whether there needs to be updates to what a child and family may be dealing with at that time. So what do developmental and neuropsychological evaluations look like? So the goal of the evaluation is to look at your child's the building blocks that make up a whole child. So that includes their thinking skills, how they problem solve, how they communicate. This includes their emotional, their social, and behavioral functioning. And this includes what supports they're getting every day and what access they have to these resources. So this can be direct cognitive testing, where you work one-on-one with a neuropsychologist or a developmental or psychologist. And this can include behavioral observations and semi-structured play observations, such as the ADOS, to look at other comorbid neuropsychiatric disorders, such as autism. And this also includes parent and teacher questionnaires, as well as clinical interview to look at adaptive functioning, social, emotional, and behavioral functioning. So what is the difference between a neuropsychological evaluation and a developmental evaluation? So many of the test measures overlap and look the same. Neuropsychologists have specialized training in brain behavior relationships, so they may be better able to understand and discuss expected neurodevelopmental trajectories. But ultimately, both evaluations will provide your family with recommendations of how to best support your child's development. And the other limiting factor is the wait lists, of course, and realistically, some of these wait lists are several years long, so sometimes it just makes sense to see the provider who you can get in with soonest, especially if there are more immediate needs. So what other assessments may be needed? So there are also diagnostic evaluations completed that can be completed with a psychiatrist or psychologist to learn more about an individual's presenting problem and to learn and to develop a treatment plan. So what that looks like is doing a clinical interview where the caregiver meets with the provider. The provider will also do behavior observations with the child, caregiver and teacher rating forms to learn more about, are these behaviors only seen in one setting versus both settings, and then sometimes there might be a functional behavior assessment done. And what that is for individuals who may have difficulty, for children who may have difficulty explaining the behaviors or the function of the behaviors, in-depth observations are made where a clinician may observe the behaviors over a period of time in different settings to look at the frequency, the antecedents, so the ABCs, so what are the triggers of the behavior, what happens before the behavior happens, to see if there's a pattern. Defining and operationalizing the behavior, so that's the B. So if it's rather than a child being angry and anger being a behavior, it's, oh, she hits or she throws a book. So it's the behavior itself that is operationalized and then consequences for the behavior. So what is maintaining these behaviors? Is it, and there's 4 functions of behaviors, so it's either escape, attention, tangible, or sensory. And dependent on what the function is, then a treatment plan can be developed, a behavior intervention plan to target those behaviors to optimize the behaviors that you want and then decrease the behaviors that you don't want. So there are state-funded early interventions I mentioned from 0 to 3, and this includes developmental therapy, speech, language, and feeding therapy, occupational therapy, physical therapy, and they may also do an assistive technology evaluation to determine methods to best allow the patient to communicate. So for example, introduction of an augmented and assisted communication device. And at 3 years old, individuals can then enroll in an early childhood or Head Start program through the public school district and receive services through an individualized education program or an IEP. And after aging out of the state-funded early interventions, school-based therapies can start through the IEP, and then outpatient therapies may also be pursued. Again, there are no practice recommendations around how many times per week these therapies are needed, and it may be somewhat patient-specific. In terms of therapies for autism, so federally or across the nation, ABA therapy services are covered for autism specifically. Individuals may receive up to 40 hours per week of therapy. It's important to note, though, that this is more challenging in reality to gain access to services. So one, you need the diagnostic evaluation for autism, and what tests are needed for that evaluation are dictated sometimes by insurance companies. There are often long wait lists for these evaluations, and some individuals who don't have autism may benefit from these therapies, but they don't meet criteria for receiving these through insurance. Other types of evidence-based therapies include parent management training. So this is often what's recommended for treatment of ADHD. So basically the goal is to train the parent and caregiver to be the experts and to be the therapists, because we know that even if a child has calm, positive behaviors in one setting, this might not apply, and this might not generalize across settings. So teaching the parents to be the specialists and then using that to disseminate to other providers that work with the child. As I mentioned, ABA therapy, or applied behavioral analysis, is another type of therapy where they really look at the functions of behaviors. As I mentioned, they'll do an FBA, and they'll look at ways to increase positive behaviors and decrease negative behaviors. Generally, behavioral therapy and all of these parent management training and ABA also fall under behavioral therapy, but behavioral therapy is basically targeting the negative behavior through a variety of different ways, and I'll talk about some of those components in a little. And then there's also cognitive behavioral therapy. This is often thought of a evidence-based gold standard, but it's important to note that because there is this cognitive component where an individual needs to be able to examine their own cognitions, it requires a developmental level of 7 years old or older to be able to participate adequately. So what are different components? So I talked about the behavior intervention plan. There's also programs that look, or components of therapy that use desensitization or exposure treatment to target anxiety or anxiety triggering situations. Developing adaptive coping skills, so teaching deep breathing, for example, or finding calming activities that support a child's functioning. Sleep hygiene, so targeting sleep from a behavioral perspective to create sleep associations and to limit factors that may be resulting in sleep disruption. And then feeding therapy. So before I mentioned feeding therapy in the context of speech therapy, which usually targets more oral motor speech or feeding problems, but in a behavioral sense, this may be increasing the repertoire of foods that a child would eat. So despite high rates of internalizing and externalizing symptoms in individuals with Dravet, psychological interventions actually have been found to be the least utilized health intervention. And there are many reasons for that. One of these being that there's not enough providers that provide services that are specific for individuals with Dravet syndrome, so that have multiple comorbidities. And some of these therapies actually have exclusion criteria. So for example, there are certain parent management training groups that exclude a child that has a diagnosis of intellectual disability. Sometimes it might be because parents don't know about these types of treatments that are available, or they're already focusing more on the medical components, and the behaviors and the emotional functioning kind of takes the back seat for a while. And then also sometimes it's because it's not recommended, so it's not something that families know to advocate for. Now going to psychopharmacologic intervention. So there have been few studies that have looked at the efficacy. So based on a paper published by Whirl and colleagues, they looked at physician and caregiver ratings of whether they thought certain medications were beneficial. So they did see that stimulant medications had moderate efficacy based on their own ratings. Sleep medications, so melatonin and clonidine, also moderate efficacy. There's been one study that is not illustrated here that looks at melatonin and compares it to a placebo, and in their study they didn't find a significant difference compared to placebo, but based on parent ratings, they did find that parents rated that those who were taking melatonin did benefit. And so one of the things the study didn't look at was sleep latency, so it's unclear whether, even though total duration of sleep did not change significantly compared to placebo, maybe there was some benefit that was noticed, or even maybe in terms of sleep quality, if there are improved symptoms the following day. And then for aggression, there's again been limited studies on this, and really only at the case study level. So aripiprazole, I'm going to butcher that one, but one of the antipsychotics was noted to be beneficial for one patient who said that risperidone was not beneficial, and then another study found that risperidone was. So academic supports. So as I mentioned, an IEP is a document that is a legal document under the Individuals with Disabilities Act, or IDEA. It is a special education law that requires equal access opportunity for all individuals. And this ensures that all children with disabilities have a free and appropriate education. So IEPs are something that are reviewed on an annual basis, and reevaluation is completed every 3 years. And an IEP is a living document, so modifications can be made at any time. So even if a child just had an IEP, but then there's a regression or there's a significant change in a child's needs, there can always be modifications to this. So this is important for families to know so they can advocate to say that they need a new IEP meeting and to get the supports their child needs. So importantly, parents and guardians have the right to invite an outside agency to accompany them at this meeting. So this can include an education liaison, a neuropsychologist or psychologist, and then legal support as well. So I'm not going to go too much into this, but basically, if you don't have an IEP but you think your child should have one, there is a formal process to request for one. In terms of placement, I often get asked by parents of what placement should my child be in? Are they in the correct one? Should it be more restrictive, or should they be in mainstream? And it really depends on the child. Typically, what is recommended is the least restrictive environment, so meaning that we want to promote the autonomy of a child, so we want to make sure that if they're able to participate in any part of the general education curriculum, then they should. This is important because it gives access to other typically developing peers, which as part of social emotional development, it's important to have those peer models that can serve for development. However, that's not always the best setting for some children, and sometimes they need a more restrictive setting where they get more individualized supports, and that might be the entire day. And there are sometimes therapeutic programs when there are significant challenging behaviors that may be getting in the way of their learning. So to have an IEP, you have to be found eligible under at least one of the following criteria. And I bolded some of the ones that are common for individuals with Dravet syndrome. So for example, other health impairment is kind of a catch-all for medical conditions that indicates there's a medical condition that impacts their access to learning. Developmental delay can be used, but this label is time limited, meaning that once they turn 9 or 10, depending on the school district, then they need to switch educational labels. They can qualify under multiple disabilities, and that means that they qualify for at least 3 of the other criteria. And some families ask, does it matter what educational label they're served under? Not really, as long as they're getting the services they need. So sometimes I'll advocate for changing the label only if I feel like the school is not capturing the supports they need, and that could be supported by a specific label. So related services are based on what a child needs to access and participate in their education. So this includes occupational therapy, physical therapy, speech therapy, social work services, nursing services, vision or hearing services, access to paraprofessional or aid. So this could be shared with other students or an individual aid, and then also having access to that behavior intervention plan. Accommodations versus modifications, so these are 2 terms just to know. Accommodations changes how a student learns, so that can be having extra time, for example, whereas modifications change what a student learns. So this involves modifying a child's curriculum to their appropriate developmental level. So some common accommodations and modifications, so I won't go into all of these, but for academic, this can include things like preferential seating, ensuring that a child has access to visuals and other manipulatives that will help with their learning, so more hands-on learning approaches. Access to making sure that a child has a visual schedule, only receives one step at a time so they're not overwhelmed. Allowing them to have extra time to respond and complete assignments, or using their best form of communication. So if they use an AAC device, for example. Medical accommodations, so extra time following a seizure to rest, and excused absences due to medical and health-related reasons. And then social, emotional, and behavioral, so that can include targeting behaviors, social skills, and prompting to use coping strategies and scheduled breaks to help break up the day. So going into transition planning. So through an IEP, a transition plan should be, is required by IDEA by 16 years old or sooner. This is state dependent. And through this transition plan, the school team should develop an appropriate measurable post-secondary goals. So this includes for employment, education and training, and independent living. The transition plan should establish a plan to reach the above goals. So how will they meet these goals year by year? And this should be updated each year, the progress to these goals, and they should be modified based on that. It's important to note that many children can continue to receive IEP services up until they're 22 years old, or until they graduate. But once you lose their IEP, you can't go back to the school. And sometimes, depending on the school district, the school may not have the transition program to support a child from 18 to 22. So a parent may need to ask for that additional programming or that referral to a high school program that has those types of services to support a child's ongoing need. And the last thing I'm going to talk about is decision making. So decisional capacity is the ability to understand and appreciate the nature and consequences of a decision regarding medical treatment or foregoing life-sustaining treatment, and the ability to reach and communicate an informed decision in the matter as determined by the attending physician. And so this is a legal process, and it's really to protect the individual with a disability. So typically at 18 years old, an individual is determined to be able to make their own decisions. However, this may not actually be in the best interest of that individual. So plenary guardianship is full guardianship, meaning that all legal decision-making would be up to the appointed guardian. There's also limited guardianship, so sometimes if an individual had like a severe specific learning disability, they may only need guardianship over certain types of decisions, and the other decisions they can make independently. And something that's new in some states is called assistive decision-making. And this is something to help preserve an individual's autonomy. But so usually those with more mild intellectual disability or borderline intellectual disability who need some assistance with making decisions and breaking down complex terms, but with that support, they are able to make decisions themselves. This sounds great in theory for some individuals, but the reality is because it's so new and it's not a formal legal process, meaning that there's a paper you print out that you have signed of who is your assisted supporter, and then some agencies don't actually recognize the form or don't know what to do with it or don't know how to adjust their language to support the individual with a disability. So there's sometimes what I recommend are safeguards. So that might mean having a release of information so that the medical system, for example, still has the ability to communicate medical information with the caregiver, a power of attorney. So if it comes to a decision where the individual really feels like they can't make the decision, make the decision, then the parent or the caregiver, the appointed person, can still make that decision for them. Having a caregiver on a bank account, for example, as another safeguard, and having an educational delegation of rights. So again, that's another, that's a way for the caregiver to have ongoing access to an individual's educational records and documents. So what next? So with improvements in medical treatment of Dravet syndrome, there's hope that the neuropsychiatric comorbidities will also be diminished. More research is needed to identify efficacious neuropsychiatric treatments, however, and we also need standardized protocols for the neuropsychiatric care of individuals with Dravet syndrome to limit delays in treatment that may impact outcomes and quality of life. All right, thank you so much. So any questions?
Hi, my kids are adults, 26 and 30, and they have had psychiatric care since they were like 4, each one. And we now see an amazing neuropsychiatrist who works really, really well with our neurologist. I would say to other parents, you know, just don't accept the diagnosis or carry it on from the school as far as, oh, you know, she's disruptive. And, you know, hopefully they won't interrupt your day with, you know, come get her. What really benefited both kids was the behavioral intervention plan. You can call a meeting, it can be part of the IEP, but don't accept, you know, bad parenting, or, you know, you're a single parent, therefore your kid has more, you know, difficulties, but just push for that. Just keep on going. If you need to get your psychiatrist or their psychiatrist to write a letter, if neurology needs to write a letter, the neuropsychologist write a letter, whatever you need, but keep pushing for it because it is your right and your child's right.
Thank you so much for sharing that.